Welcome to Profits in Practice, the podcast where medicine meets money. Hosted by myself, Sarah Webb, Managing Director of Webb CFO, and financial strategist for physicians. We break down the numbers, decode the tax code, and help doctors build lasting wealth, one episode at a time. This episode is powered by the Specialty Healthcare Consortium. Dr. Tracy, thanks for joining us again.
Thank you, Sarah. I'm glad to be here again.
Yes, absolutely. Well, one of the things I wanted to talk about was the obstacles to care and how that's kind of changed over time. Tell me a little bit about your thoughts of, the landscape of what it is today versus what it used to be.
Well, I think the biggest change over time is the complexity of insurance coverage, of carrier acquisition, access to care, access to specialties, access to medications, especially as medications have gotten more expensive. Um, we have a lot of tools in our toolbox, but we can't always or certainly easily get access to those tools for our patients. That's really a challenge, and I actually think that there's a fairly active choice by somebody to actually not prescribe medications because from a cost standpoint. So healthcare providers are on one side of the scene. Obviously, patients are with them. On the other side is the people that we refer to as payers. And that payers can be broadly broken down into government payers as well as non-governmental, like Blue Cross Blue Shield,
Insurance carriers.
Insurance carriers. And so they're each of those avenues have challenges embedded within them. The private carriers are probably the most complicated because they tend to be the most variable. It's hard to keep track of who has what deductible, what is their co-insurance, what's on their approved drug plan, and how that goes. And the system is built to deny access. And so the only way to get over that denial hump is to basically appeal. Well, appeal costs time.
And money.
And
Lots of money.
Time is money. And so a lot of practices don't have the infrastructure or the time, or in this case, the money to actually get that to the patient. So they tend to get left behind. And it's my personal opinion, that's the system of payers designs it so way to make it more burdensome for me to provide care, because if I don't provide that care, there's no expense for them. You might say, well, isn't it to their benefit to not have people sick? To a certain extent, there is. But we know from data, and I don't remember the exact numbers, I wish I'd prepped better for this, but I think the average insurance plan covers a patient's life for 3.2 years or something like that, versus say a lifetime. Sure. So if you're going to spend a lot of money, but the long term, maybe 10, 15, 20 years down range is going to be successful, hey, that makes it worse. But if you're just picking up the burden for the 2-month, flip around, they want somebody else to pick up that tab. In the private world, it's often the private carriers want to get the government to pay for that. And so you got to navigate that. And so there's a lot of ways to do it, but frankly, a lot of providers give up because they don't have the time or the resources to do that. So that's the obstacle.
No, I was reading this past week, I think it's 85+% of, denied claims are never reworked. And so, what happens? There's a lot of things that happen in that process, right? Sometimes you've given the medication to the patient and you're just now out for whatever that is, or the patient doesn't get the care, right? Because it's never dispensed. So sure. I think it's a big problem it's a problem from like a work process flow, right? Like that stuff gets left behind, but even just the patient care, the patient is missing out in that benefit for sure.
Well, and I actually saw that article too. Yeah. So in that case, there's not enough granularity to see exactly what they're talking about there, but I will say this: what happens is that's usually pharmacy benefits.
Correct.
So the way it works nowadays, I see a patient, and then at the end of the visit, I formulate a plan. With that plan is a variety of medications. Those medications are sent in most cases electronically to your local pharmacy, and then depending again the medication, it's not necessarily a complicated medication
Sure.
or even necessarily an expensive medication, but denial comes back. So and so if the patient, again, a little depends on the
Yeah.
patient, but what happens then it comes back to the provider, which may be a nurse, it might be the physician. Um, they have to explain why or the rationale for that. And that takes time. And if you don't have time, you just don't deal with it.
Yeah. Yeah.
And so the 85% denial is that. So in the case of my practice, I'm in Omaha, Nebraska, and I have the infrastructure and the ability and the motivation to kind of work through a lot of that stuff. And that's just the simple stuff.
Yeah.
Now, sometimes, if you don't like this drug you got drugs A, B, C, D, and they come back, well, B and C are in the, and I look at it, "Oh, that's not too bad. So we'll go ahead and do that." I'm okay with that. Um, but in the case of more expensive medications, they just don't want to pay it. So somebody has to, pick up that bale of
Yeah.
water or cotton and get it past the finish line.
Yeah. Tell me a little bit about your legislative work because I think one of the ways, it's not easy, definitely, and it's slow, right? But how do physicians work as a group to bring up these issues? I mean, obviously, just complaining to the carriers is not going to work. And so, what are some other mechanisms that we can attempt to change the system?
Well, they have, when it comes to private carriers, they have effectively no leverage there. When it comes to governments, Medicare, Medicaid, other things like TRICARE, for example,
Hmm.
um, and there's really it's a little. There's a couple of different ways. So the first way is it's done through medical associations. So the AMA may have a position, or your Texas Medical
Hmm.
Association may have a position, or in my case, the Nebraska Medical Association. What they may do is they may, and there are several groups out there that do this as advocates for patient access. And there's actually a group called Alliance for Patient Access. And so what they do is they tee up individuals, again, depending on the disease state and the area of the country where they want to make change, to kind of move that group. It starts with awareness, then you build up a kind of a response, and depending on where it's going, you may you motivate or bring into the picture physicians or care providers that can maybe go to a hearing for your state Medicaid. So that's one angle to do it. The other angle, which is actually probably more effective, is actually, I won't say more effective, so I'll circle back to that in a second, is really bringing in parents and
Yeah,
patients. When it comes to really high impact, emotionally impact, there is nothing more motivated than a mother of a sick child.
that
There
is.
is nothing. Mothers, dads are motivated. Don't get me wrong. I'm not dissing on dads, but mothers tend to blame themselves for the problem. And so when they go before, in this case, Medicare or Medicaid, they're a powerful advocate. And and so nobody wants to be seen slamming the door on a mother who's advocating for their baby
Yeah.
ever.
Yeah.
I mean,
And the mama bear, right? I mean,
it's for
she's
sure. And so now the best is really when you pull those two groups together.
okay.
And so in my other role, which we've mentioned in the past podcast, is in my work with the American College of Allergy, Asthma, and Immunology. So we have specific strategic goals, mostly as it relates to access of care.
Okay.
And so what we do is I'll pair up myself as a provider, a
Hmm.
specialty provider, with a mom, or last year was actually with a mother and 11-year-old,
Okay.
and we'll go into the room together to meet with the senator, the congressman, most likely one of their staffers that looks at medical issues. Some are naturally more responsive. Some really are fairly indifferent. The harsh reality on Capitol Hill is that most healthcare issues, your local representatives are fairly indifferent,
Hmm.
and that can be a little discouraging. But
Is that because of the way things are set at the state versus the federal level? I mean, is that a little bit of the play, or it's just not
well, so
heartstringy enough?
yeah, so one of our representatives said, what, this is very complicated. Well, I mean, so is war, but you deal with that.
Yeah.
Okay, so and so what makes this so difficult? In fact, I would argue that not only is it less difficult than those complex diplomatic things, it's actually relatively low-hanging fruit.
Hmm.
And so 2 years ago, maybe three now, there was this big fiasco with what was called Change Healthcare,
Yes.
and it was with Optum, who controlled basically the reimbursement for literally three-quarters of really the country.
Yeah, it was Americans. Yes.
It was really, and so um, I don't know whether well, it got fixed eventually. It was basically caused by a glitch at United Healthcare, and they apologized. They didn't help anybody. They did apologize. Congratulations, United Healthcare. But when I went to Congress, I raised this as a national security issue. This was not just not paying people because you didn't want to pay them, or you accidentally had a glitch that couldn't pay them. You had a breakdown from a technology infrastructure standpoint, which in this case was change in medical reimbursements, without getting into the details. But you know what? It could have been the electrical power
Sure.
grid. It
Yeah,
could
it
have
could have
been
been
a
a
whole
number
myriad
of
of things.
things. Yes.
And so if you look at it like that, so that's one way to get their attention. Um, and sometimes but in general, when it's just, access to care, the rules of Medicare, they see that as a policy thing, that less a legislative thing. So when you look at it from a governmental standpoint, there's policy and then there's legislative. And so what Congress does is it legislates laws that govern things like Medicare
Mhm.
and all that stuff. So then the agency, in this case CMS, Center for Medicare Services, basically establishes the policies. So CMS implements those policies, which are legislated by Congress. So and so you got to kind of understand how that works. And so most things are actually handled at the procedural standpoint, and knowing where those levers are is really important. And to your earlier question, the way you do that or know where to go is usually through some organized medication medicine part. And so earlier I mentioned, how do you get involved? Well,
Right.
that's how you get involved.
When you say the medical association, like they're helping you connect with legislators or lobbying groups?
Yeah, well, it's really both. They may alert you.
Okay.
So there's what I refer to as offensive lobbying and defensive lobbying. Defensive lobbying is being aware of what's out there, so that you can
Whack-a-mole, like
well,
complain.
or react in whatever
Okay.
way you feel is appropriate. Offensive lobbying is I'm going in to say, I want Senator Webb. This is an issue. It's important for your constituents. You need to pay attention. That would be offensive, whatever that
Mhm.
situation.
Yes.
And so where the medical associations do is they're pretty good at the defensive side, and then within the constructs of especially Capitol Hill, but also at the state level, and there's lobbyists.
Yeah.
And what they do is they gain you access to make your point. That's what lobbyists do. And in the healthcare, it's mostly, doctors, physicians. Well, for where I'm at, doctors, physicians, and lay folks, mostly women. On the hospital side, they have a huge, lobby that is very aggressive and very involved with how those things affect them.
Yeah.
Each of those two groups have different cost pressures.
What was besides being active in the college, like what was it that you saw or you wanted to get active in that made you want to kind of pick up this legislative piece? I mean, what was like that first tug of like, oh, this might be something I might be interested in, good at, active in?
Yeah. So I've always been interested in advocacy at multiple levels. Um, to get to the point where you're actually on the Hill, you kind of, to a certain sense, you sort of self-select. In other cases, you are selected because of some connection.
Voluntold.
Well, you may have access to somebody.
That's true.
Okay, so if my senator or congressman is on a particular committee, I might be approached because I'm a voter for this person, this constituent. I'm a constituent for this particular senator or congressman. And where like for example, Texas, if I had an appointment with a Texas congressman, that's going to have a different impact whether you go to that congressman,
Right.
because you're one of their constituents. So that might be one way. Um, And then in my various roles from an executive leadership standpoint, it's my role organizationally to do that. So it kind of just depends. But when I go to Capitol Hill in 2 weeks, we'll have two groups. on day one, it'll be really fairly targeted, like targeted in, and their constituents aren't that important, but you're going to be going like to the Senate Help Committee. Basically, they both have caucuses and trying to make your point to these various caucuses. Now you can do that as a group. So that's kind of doesn't really matter where you're from.
Yeah.
You're doing that at the executive level to an executive group.
How have you seen, like, putting on, like, the leadership hat of, like, the change management of some of these things happening? Like, you talked about informing, advocacy. Where do you see other physicians kind of fitting into this space?
Well, it's a lot of work. The probably the singularly the most important thing to do if you have the time is to be able to testify in a committee. If you can't testify in a committee, write a letter to whoever.
Mm.
So right now there's a new form of uh, epinephrine that's available.
Yes.
And it's called Neffy. And but historically there's injectable epinephrines that are out there, and those are all on the various pharmacy panels really for all 50 states. Um, and change is challenging. And in the case of Neffy, even though it's not necessarily more expensive, it's different.
Mm.
And so the way you make those, and there's a lot of reasons why you should be prescribing this. I would say that as a caregiver. And I need to convince you that whatever your obstacles are, cost or whatever, and the only way to do that is really through a letter, unless it goes to, it's called the Pharmacy and Therapeutics Board, and almost all states have those for Medicaid, and to get it on their list. So if you get access to that committee, that's huge. Um, that's where being involved with the state medical association, because they can give you, the access. They can at least tell you when the dates for the committee hearing is. Then you can petition for a hearing, because there's always public hearings. You just you petition. So in my other role, which you didn't ask me about, but I'll just kind of layer on. So I was on the Pulmonary Allergy Drug Advisory Committee for 15 years for the FDA.
Okay.
And so there's a very now we're dealing with this is mostly at the policy level. And so with every new drug that comes out, there's an opportunity for public hearing. It doesn't have to be a physician. Oftentimes it is. Kind of depends on the situation. And that's another opportunity to get involved. But you got to know when that meeting is going to be and what are the accesses to input that opinion or that comment. And that usually is brought to you by a third party.
Yeah. Um, Talking about the FDA, what do you see? So that third party, how do physicians get connected? Are the third parties coming to you, or you, I don't say befriending your MSL, but right, like creating relationships with different pharmaceuticals? What does that sometimes look like?
Yeah. So again, it depends. So it's kind of self-selecting. If let's say I take care of, I'll give you an example. So there was a drug that came up for cystic fibrosis about 10 years ago. And the physicians and parents, again, mostly mothers,
Mhm.
testified for that. And so they sort of self-selected because in the case of the caregivers, they saw a need for this drug. They
Right.
saw a spot for this drug. They understood this was not an inexpensive, choice, but it was for a condition which is almost universally terminal, like cystic fibrosis. It's an opportunity. So the physicians who testified were physicians who took care of these types of patients. And they were doing it not for their personal gain, but for the gain of their patients. The parents were doing the same thing. So they know it's out there. Nowadays with social media,
Yeah.
Facebook, it's a challenge for us, but it's an opportunity for them to stay connected and know what's going on. Because good news as well as bad news travels like wildfire on social media. And so that's how and so you self-select.
Yeah. No, I love the idea of really change management from an advocacy standpoint. You started at the beginning, the advocacy, the obstacles of care for your patients. It's always about the patient. All the other stuff is surrounding it, and your practice has to be sustainable, right? To be able to continue to serve patients, and that's what we talk about a lot with our clients. I think sometimes physicians feel like it's dirty or it's not noble to earn a living, or to have a profitable practice. And I kind of just push back. Again, I'm a money person, but I'm like, you serving, like, if you're not able to be sustainable as a practice, you're not going to be able to serve your patients. You're not doing the good that you want to do if you're stuck in a bad situation.
I've struggled with that a little bit. on my own. And so there are definitely physicians who who they kind of don't get it sometimes. Like they should be guilty because they're making a living. I mean, most physicians walk out of medical school with nearly a $500,000
Yeah.
in debt. And so that's affected the flow of access to care. And it's hard for a family doctor to pay off a really effective
Yeah.
amounts of 2 house payments every month for literally 30 years,
Yes.
which in the case of their career, that's their career life. And so you don't feel guilty about making a living. I mean, I often talk about, you've heard me use the word sustainability.
Hmm.
So I specifically choose that word over profitability because profitability does carry with it a certain negative
Sure.
connotation in certain circles. Now, in other circles, like in the finance world, profitability is
Yeah.
not a bad word, but in the medical field, it is. And so by reframing that issue into sustainable versus profitable, you come to the same point, but you hopefully there's a little less guilt getting there.
Yeah.
And so if you could figure that one out, that's really great. I actually got an award years ago, and there was 4 faculty members. These are big name people, very smart people. And so they were getting this award because greatest teacher, I mean, whatever it was. And the award that I got was from the American Academy of Allergy and Immunology. It was basically for RSL leadership, regional, state, local society, kind of what we're talking about, leadership. And I said, they were talking about their great inventions and their great discoveries. I said, "Hey, I just want your fellows, your trainees to be able to make a living."
Yeah.
It's pretty simple. And so that's kind of what I carried through with this. And so everything I do with the consortium is really geared around that because I think that you ought not to feel guilty for making a living. I mean, you've got families, and I've talked in the past about the people that work under me.
Yeah.
Don't feel guilty. You get paid.
Yeah.
And so, putting a little context on that, so everybody looks at that a little differently. So, in the community-based situation where I'm at, those breakpoints of sustainability are a little more obvious. If you're in a very large group or multi-specialty group, um, or if you're in an academic center, what happens is you're kind of shielded from some of that stuff
Yeah.
because of the
Yeah.
bigger system. So but even then, I think that they shouldn't feel guilty about, making a living.
Yeah. No, that's what we talk about in practicing kind of the operationalizing of the clinics and the practices. Because, I mean, it's not being sustainable is important, but it's also, it doesn't have to always be so hard. And sometimes I think we over engineer things and they become over time a certain way because someone did it a certain way. And, it doesn't always have to be that way. So
Change is hard.
change is hard. And it's around us all the time, and so it's important to kind of step back sometimes. And even in my own like professional practice, and I preach this all the time, I have to like give myself a timeout. I'm like, okay, I need to like look at this as a consultant of what would I do, what would I change if I came into this practice that I would do differently. So I like to challenge myself too.
Well, one of the things I've learned is, and I've mentioned this in the past, I'm not the smartest person in the room. I'm pretty good on a lot of stuff, but I don't understand things like contract negotiations. I don't understand mergers and acquisitions. I'm pretty good with the P&L, but I can't pull it apart like, say, like you can do. I can't see where the loops are and where the trap doors are, and I need somebody to do that. But I also have to have the courage to actually ask that question. And so, that's a challenge. And
Yeah.
so, and a lot of providers don't know how to do that, and they get caught because sometimes, especially if they're in a large group or even academic world, they other people say, "Oh, just believe it, believe it, believe it." Well, if you understand, where the money's flowing, it's kind of a metaphor, I guess. So, as I tried to move budgetary items through when I was with the American College of Allergy, Asthma, and Immunology, I used to joke that I may not know where the skeletons are being buried, but I did know how much it cost to bury them. And so, but understanding that is really critical to understanding flow payment, understanding the obstacles that we touched on at the
Yeah.
beginning of this talk. If you don't pay attention to those details, you don't have to know it like an accountant.
Correct.
You just need to figure out who's the best person to get at the table to help you, navigate those those challenges.
Yeah, absolutely. Well, thank you for joining me today. It's always a pleasure. I always learn something new about you, but also about the profession.
Perfect. Thank you.
Thank you. Thanks for tuning in to Profits in Practice. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with a fellow physician. Your financial wellness is just as important as your patient's health, and we're here to help you thrive. Connect with us via our website, webcfo.com, and connect with our guest at sh-consortium.com to find out more about the consortium.